usual cooperation. I want to talk about the report that you every year on the financial viability for each province. If we look at the 2023 report, five provinces, given their GDP, seem to be viable. Five others aren't, and the territories are not. 50% of the provincial governments, including Quebec, have long-term risks if we have additional public spending. So my question is, again, hypothetical, but based on your analysis, if the government sets up a major program like Pharmacare and decides to reduce its share of the spending, what will that mean for the financial viability for Quebec and the provinces? If the government provides considerable funding to a national program and then progressively reduces its funding or withdraws from it, inevitably that makes it difficult for provinces. They have to decide either to ante up more money or to reduce the offer for the provinces that decide to continue coverage. Thank you, Mr. Giroux. Thank you, Mr. Blanchet-Jonca. Mr. Julian, you have 6 minutes.
Chair, and I mentioned earlier this is a historic moment, historic hearings, and cited a number of important organizations. I did want to shout out to the Canadian Labour Congress, B. Brusk, President. They have submitted a memoir to this committee saying that the Canadian Labour Congress calls for the speedy passage of Bill C-64, an act respecting pharmacare, before the House of Commons and the Senate adjourns for the summer so that millions of Canadians can access contraception and diabetes drug and device coverage, giving them some relief from the high cost of living. And I would note that Elizabeth Kwan from the CLC is here in the room today. And, of course, wanted to shout out to the Canadian Health Coalition and thank Mr. Staples for being here. Mr. Staples, we've heard from one party in the House of Commons, the Conservatives, and from a number of lobbyists that the system's working really, really well. What we have in pharmacare now just works well in Canada. You deal with frontline workers, nurses. Is it true that everything is just fine when it comes to access to medication? And my second question to you is the issue of a pharmacare program. Is it true that a pharmacare program will help save healthcare dollars?
Thank you very much. Mr. Julian, I share your concern. When I hear witnesses say the system's working very well, I ask for who is it working very well? We just heard from Mike Blisky. It doesn't sound like the system's working very well for him. So it seems to be working for industry and insurance companies, but it's not working well for all Canadians. So that's why this Pharmacare Act is so important. We must get this Bill C-64 through. And it makes me, again, also hearing that the Canadian Health Act, in the view of industry, creates uncertainty. I would differ. I think the Canada Health Act is very important. For 40 years, it's made a guarantee that Canadians, when they need medical care, they will get it not based on who they work for or what insurance program or how much money they have. They'll get the care because they need it. So I'm very passionate that the CHA creates certainty for Canadians, and we want that system. We don't want a U.S. system. So when I hear frontline workers talk, and they do, and we had 100 frontline healthcare workers come here in February, met with many members of this committee, and I express my gratitude for all of you who took time out to meet, very busy time. These are people that are working with all kinds of issues in their hospitals, in their healthcare environments, but they took time to come to Ottawa to talk about the importance of pharmacare. I mean, that really, with all the challenges that they face in the healthcare system, and you know why? When I hear they say filled prescriptions means empty emergency rooms. They know that if people are getting their medication, if they're not cutting their meds, if they're not making choices today whether to take their medicine or not, they don't end up presenting themselves with far worse conditions in the emergency wards. And that's where a lot of cost savings can come in that we're not hearing about. Of course, there's cost savings for individuals. Of course, there's cost savings for bulk purchasing. We can get those prices down, get them down to the median of OECD countries because they're so high. But also, it saves the healthcare system. St. Michael's Hospital did a study. They took 700 patients who had trouble economically paying for their medication. And these patients went out into the world after they were diagnosed. They mailed free medication to half of them. The other half, they just let them fend for themselves based on whatever that system that we were talking about a minute ago, however that system works out. Well, they found that those people that had free medication provided to them did far better. They recovered faster. And, in fact, they could even put a number on it. It saved $1,600 a year per patient who received free medication. So that's an important factor in looking at how we can save money in a national universal single-payer program.
Thank you very much. I wanted to go on to Mr. Blaski, and I hope you get questions from the Conservatives because you're a real-world person who lives in the situation that exists right now, which is catastrophic for so many Canadians. What would happen if you simply don't have any contracts? You do not have the money for a month. What would happen to you if you're not able to purchase the medication and devices? And I also wanted to ask, where do you buy your diabetes supplies as well?
Well, in my case, I mean, I have very little of a safety net left, so I would mean dipping into my line of credit. That's basically what it comes down to, because once again, I'm part of the Ontario drug benefit, so that is basically what is offered to all Ontarians who are low income, and that low income assistance for prescriptions only covers the insulin itself. It doesn't cover all the other aspects. So for those that are taking injections, it doesn't cover syringes. It does not cover needle tips. It does cover a glucometer. But for those that are using an insulin pump like myself, it doesn't cover the CGM, which I needed in order for the pump to work properly. And when it comes to purchasing my supplies, I can give an example here. So I end up buying my stuff directly from the suppliers, and in many ways.
Yes, Dr. Ellis. Yeah.
I hate to do this to the witness, but we've already discussed this previously at this committee that there's not going to be any props and doing a show and tell here. I think that's been well established. It may well be helpful, but I think that we need to continue to follow the rules here. Okay, then I'll do without. So in terms of the individual aspects that I have to order, so CGM I have to order on a subscription model directly from the company, Dexcom, and that is $200 a month, and then they ship it every 3 months, and that is basically a 3-month contract that I have to renew all the time. When it comes to the individual pump supplies, the company that makes my pump, which is called Tandem, only offers one single supplier, and that is a company called Diabetes Express, which is a subsidiary of Bayshore Health, which is a subsidiary of Shoppers Drug Mart, and they are the only people that I can order those supplies from, so I have to wait for those things to come in from Toronto. In one case, I actually ended up nearly missing a shipment because there was delays in the mail system. If I was able to actually have more access.
Thank you, Mr. Leske. Yeah, thank you. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you very much, everyone, for being here. Appreciate your presentations. It's interesting that we heard one of our members repeat something that I've sort of hit on a number of times, is basically targeting efforts where the need is supposedly supposed to be. Mr. Frank, you sort of hit that right on nail on the head. You talk about the use of $1.5 billion and putting it to a situation where it may be more effective. Ultimately, when we look at stats that suggest that 1.1 million Canadians don't have any type of plan, and up to 3.8 million having
are not either aware of a plan that they could have or don't have the funds or choose not to do it. It's a 10% population of Canada, roughly, that it doesn't have access to it. But putting that 1.5 billion to that population, I wonder if you would expand on where you think that might be of great value.
Run some simple math on this. It's going to depend on how broad a list of medications you cover, but the typical cost for someone on the ODB program here in Ontario is roughly $1,900 a year. And so if you take that 1.5 billion, if that was an annual thing, you could probably cover most of that gap and provide access on the ODB. So these are just, I think it's an illustration of the choices that we can make, targeting federal funds where it will make the most impact. Using money to simply replicate what's already in place for 27 million people is, in our view, not the best use of scarce federal resources. And in fact, switching people off of a private plan onto a public risks them actually having weaker coverage than they do today. So I think the vision the minister outlined this morning, we are completely aligned with. I'm not aware of anybody who's suggesting the system can't be improved. I don't think anyone has argued that today. But we should be targeting our efforts where the need is and not risking disrupting what's working for the large majority of Canadians. As you said, that's sort of 90% of Canadians today.
Thank you for that. And we've heard throughout today, and I think there's been many comments and talked about this legislation not being clear. And it doesn't define things appropriately. I mean, it puts in definitions for a minister, but doesn't put in definition for a first payer. It's very unclear in many ways. And Mr. Keon, you also talked about issues that we're not defining, in particular when we talk about the bulk purchasing. And I'm wondering if there was a way to take a look at that bulk purchasing, would there be any suggestions that you might have to add to that?
Thank you. We would remove the term. We don't like the term. I mentioned that we negotiate our prices with provincial governments. The three large federal plans are included in those negotiations. Our prices apply to all Canadians. Public and private reimbursed prescriptions are all at the same price for generic medicines. It is a universal plan. It is a national plan we have. It is negotiated with our industry and the experts who run the drug programs, who know what the drugs do. And it is the most recent one, just came into force in October. We would like to see that continued and respected. And we think that the term bulk purchasing is very unclear, and we're not sure what it means in the bill. So we would like to see it removed.
Thank you for that. I appreciate it. Mr. Giroux, and it's good to have you here. And I recall one of the first meetings that we had when I was chair of the government operations, and the discussions we were having about finances, and in many ways I felt that you were apologizing for the fact that where we used to use terminologies of millions of dollars, we're now using the terminology billions of dollars. And I think Canadians need to understand that. They really don't understand that we've made that. As I said to you at the time, my wife and I used to talk about nickels and dimes. And now we're talking, instead of millions of dollars, we're talking billions of dollars with this government and the huge amounts of the costs. So when we look at the costs, and in particular, you talked about the $1.9 billion. One of the things that I'm just wondering if you can clarify, especially for someone, because I do have your report here with me, and where you talked about the public drug plans will be $14.8 billion in 2024, increasing to $17.3 billion in 27-28. And I'm just wondering, for people who hear these numbers being thrown all about, they hear numbers and they just question, okay, what are we talking about here when we hear $1.9 billion over 5 years versus
Dr. Kitchen, you're
numbers
past
like
time.
that?
If you can get to your question, we'll ask for a brief response.
If you just comment on that, please.
Briefly, please.
That we referred to in our October 2013 report are the aggregate expenditures on public drug plans, and they are expected to increase, and that's the cost for the drugs that would be covered under a national pharmacare program.
Thank you, Mr. Giroux. Dr. Kitchen. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. My first question is to the Canadian Health Coalition. I know Mr. Julian touched on that a little bit, but I want to ask that, we know that 1 in 10 Canadians with the chronic conditions having ended up into the emergency rooms due to worsening health because they were unable to afford the prescription medications. This is a serious burden on our nurses and doctors and on our healthcare teams in the general. Do you have any number to share with this committee and how this legislation is reducing the burden on the healthcare system?
Thank you very much for the question. You know, there's a term that I've read. It's called cost-related non-adherence, and it means when people are cutting pills, when they're skipping, they're taking their medication that their doctor or care provider has prescribed to them, and they do it because they can't afford it. And you know, it's not even just a simple matter of having insurance, because many insurance programs have copays, and some of these copays can be very big. I live in a community of Regent Park in Toronto. It's a very mixed community, and I was just in my drugstore just the other day when there was a customer in front of me, went out to the counter, and they had to ask what the copay was. And the pharmacist said $14 for whatever it was he was getting. He kind of paused, thought, mumbled to himself, I think I can get that cheaper, and turned and left. And I don't know what happens. And how long does that go on, and do they end up in a hospital somewhere? So we've seen this. I've had nurses tell me they've seen patients who cut their medication and ended up in very serious conditions in the hospital. And as I mentioned, I would refer to this study from St. Michael's that did find $1,600 a year of a savings that can be made by having people having free access to their medication. So that's just a start, and I'm very excited that we can see what this program brings in on these 2 classes of medications. We'll have the expert panel. We'll get a report back, and I think it's going to be very encouraging.
Thank you. My next question is to Mr. Blasky. When you said insulin is not a luxury, it's a necessity. So before that, I was working on Bill C-237. It's a national framework for diabetes. I know untreated diabetes with the serious consequences. So how you feel that, like the person like you, with this legislation, definitely will impact on the life of the quality of that person's life? You want to elaborate on that? What do you think about that?
Absolutely. For me, this has been something that I have been asking for and advocating for since I was in grade 7. One of the very first things I did when I was a type 1 diabetic was attend an all-candidates debate in 2006 and ask about, how could I make my life more affordable? And so I know that there are so many different diabetics out there that want to be able to say, I have access to the life-sustaining therapy that I need, because as has been said before, rationing is a huge problem, and it means that people are facing the complications of blindness, of nerve damage, of amputations, and I believe that if every single person with type 1 diabetes had access to the medications that we need in order to survive, the overall burden on the healthcare system will be immensely measurable. But for me personally, I know, when I've had those scares when it comes to, having to talk to an expert about, what will my eyesight look like in 10, 20 years, I can be more comfortable with knowing that my eyesight's being protected, that I'm not going to have to face permanent disability. Those are the kinds of things that I look forward to when this bill comes into play.
Thank you. My next question is to Mr. Giroux. Your report mentioned behavioral effects on this legislation. Have you considered possible savings to our healthcare system due to increased support for people with chronic conditions that can prevent them from going to emergency room? So it will reduce the healthcare burden, healthcare cost too.
The short answer to your question is no. The mandate of my office is to provide costing and cost estimates. So we rarely do cost-benefit analysis for that very reason, unless we're specifically mandated to do that by a very focused request. But generally, we don't do that.
Thank you.
Thank you, Ms. Sidou. Monsieur Blanchette-Chonka pour 2 minutes et demie.
2.5 minutes. Thank you, Mr. Chairman. I will follow up with Mr. Giroux. I have your analysis on Bill C-64. You indicate that there is uncertainty given the lack of information on all of the things included. So you also talk about the medications, the drugs that aren't in the list. So I have a simple question for you. Do you think that it would be possible that the number of drugs covered might be lower than with this kind of program? Yes, it is possible. The analysis is a technical document. There is a list of drugs that will be covered, and there may be other types of contraceptives, for example, or diabetic drugs that might not be covered. There may be substitutions as well. And what people have been using may not be covered in the same way. Okay? Are there other aspects of your report that you would like to highlight for the committee? No. Maybe my colleague has something? No. Ms. Barkova, I read that you took data from another organization, that is the Canadian Health Information Group, that provided information to you. So I'm trying to understand if we want to have a more clear picture, because this is all kind of theoretical, if we really want to be able to analyze this situation, what extra information do you need from the government so that you could be much more specific?
Comes to mind is having the clear terms and clear requirements for the program, like the specific list of drugs. Like we know now that it's still to be negotiated, so once we know for sure which drugs are included, it will help us to have a better understanding how to cost such a program and provide a better estimate.
Thank you, Ms. Barkova and Mr. Blanchette-Chonka. Next, Mr. Julian, please, for 2.5 minutes.
Thanks, Mr. Chair. Mr. Blesky, I wanted to come back to you because my question to you in the last round was, what would happen if you couldn't go into your line of credit? You simply don't have contracts. You are unable to take your medication. What does that mean in terms of your own personal health? Because I think that's important to share with the committee, and all members need to understand what the impacts are, the current situation when people can't pay for their medication.
If we're talking about the hypothetical of, actually, cutting into my insulin and like either rationing my insulin or stopping my insulin entirely, by cutting down on my insulin, it means things like becoming blind due to diabetes-related macular problems, diabetic retinopathy. It means neuropathy, which means that it starts with a tingling and a numbness in your legs, which ends up turning into excruciating pain, which also means that there's low blood circulation in your limbs. So that means you're more susceptible to injuries and cuts. And as you don't feel those injuries, they fester, and those complications end up, leading to amputations. Other effects are long-term kidney damage, long-term liver damage, because all that sugar in your system has to be flushed somehow. So your kidneys and your liver end up working overtime in order to get that glucose out of your system.
Is that reversible?
No. Pretty much any change that as a result of high blood sugar, like there are acute symptoms and then there are the long-term symptoms, and the long-term symptoms are completely irreversible, which eventually they lead to fatalities, especially when it comes to ketoacidosis, which is the most acute form of high blood sugars, and that oftentimes comes in very, very quickly as soon as a diabetic loses access to their insulin. So
how long?
If I had to stop taking insulin, I would probably be in the hospital within a day or less. It can be that fast.
Thank you. I can't understand why anyone would oppose this legislation.
Yeah. Thank you, Mr. Julian. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. So I have a series of questions, but I guess I'm going to start out with to you, Mr. Frank. Workplace benefit plans. So if a workplace decides that they want to add a particular drug or service, is there a possibility to add just one service?
Well, yes. I mean, if you mean by service, so a typical plan would cover prescription drugs, would have dental coverage, vision coverage, would have all the paramedical services, travel. So there's a suite of solutions that can be provided there. And employers can have some flexibility into what they want to offer. At the end of the day, it's their choice what package they want to offer to their employees rather. With respect to the drug class, yes, we absolutely do see employers covering certain classes of drugs and not others. You tend to see that in the higher cost areas. Some of the rare disease spaces, for example, certain medications would be considered on, and often different employers will have a different tolerance for how much risk and cost they're prepared to sustain. So we do have a variability in what's offered to Canadians. And
based on that, if this bill were to go forward, would you be concerned that employers would come to you asking to have these two classes of drugs removed from their current plans, therefore driving up the cost to taxpayers?
that is a concern, and I think, again, if you read the legislation, it doesn't stop at those two drugs, and I think that's one of the big things we need to keep reminding ourselves. It contemplates within a year going well beyond that. And so if you get into a situation where hundreds or thousands of medications are covered, then absolutely employers are going to start asking themselves, you know, why should I be still in the game? And so we work really hard to educate them on the value of the programs that they're offering their employees. They, like I said, tends to be more flexible, much broader than what they may get on a public plan. But that pressure and those questions will start if this bill, you know, 2 years down the road has come to fruition. And so I think, and again, that's not the vision that we heard from the minister today. So I think that disconnect is what's giving us pause.
No, and I appreciate that. And I really do appreciate, Mr. Bolesky, you sharing your lived experience when it comes to your experience with the OHIP plan or OHIP Plus. As someone from Alberta, I'm not terribly familiar with Ontario's plan. So I did find that to be quite insightful. I'm frustrated in large part as we're studying this bill that we don't have the opportunity to hear from all different provincial plans to see where those gaps particularly are, because I don't necessarily know if those gaps are the same in every single province. And so my question becomes, are we creating, potentially by going down this path, are we solving for a problem that might not exist equally across the provinces, and therefore creating a situation where we are going to reward provinces that have done very little and perhaps not provide that, which would therefore ask the question of, would provinces continue to offer these kinds of plans if they were to not do this? So this becomes this very circular question of creation and complications. So my question to Mr. Giroux, when you have put forward your prescription costings in your most recent budget, did you factor in the record-breaking inflation we're facing in the future costings?
Yes, we took into account inflation, past inflation, as well as our projections for future inflation.
So did you also factor in if provinces were to drop some of these drugs from their existing plans?
No, we did not include any potential provinces reducing coverage for diabetes and contraceptives.
So this could potentially cost substantially more if provinces and territorial plans decided to remove these drugs as a result of this legislation.
It is indeed a risk, as would some some employers, who could decide to reduce their coverage, knowing that there is a public plan that would cover their employees.
So effectively, we have very little idea how much just these two drug categories will effectively cost the federal government. So we're being asked to vote on something that we have no clue how much it's going to cost.
Well, I wouldn't say we have no clue, but there's quite a bit of uncertainty regarding the costing of such a plan. Public plans and private plans to offload some of their responsibilities onto the public plan.
I find that very concerning, and I want to thank all of you guys for being here today. Thank you.
Thank you, Ms. Goodrich. Dr. Hanley, please, for 5 minutes.
Yeah, thank you very much, all of you, for being here and for the interesting testimony. Just briefly, maybe to follow up, Monsieur Giroux, on some of your answers. I note there's no territorial analysis. Is there a reason obtaining data? Is it about small numbers, or can you just clarify why territories are not included in the analysis?
It just simply comes down to the fact that the data that we use for this analysis contains only provincial data. Had we had territorial data, of course, we would like to include that in our analysis.
Yeah, would love to see that included in future analysis. Thank you. And can you comment towards the end? And forgive me for not really perhaps understanding as well as I should, but maybe I'm representing Canadians to some extent as well. But economy-wide savings. So you say drug expenditures in Canada would be reduced by having a single payer due to a few factors, including increasing negotiating power. So could you just comment on give me a bit more explanation on what you mean by economy-wide savings?
Sure, and you're probably referring to our October 2023 report, where we costed a Canada-wide single-payer universal plan that would cover most drugs. So in that case, we assume that the bargaining power of the federal government would allow the single-payer, well, I say federal government, it could be individual provinces, but let's not get lost in these details. So a single payer would have a negotiating power and could presumably also be able to negotiate additional rebates. And that's where the economies would come from. And they would probably more than offset the coverage of those who don't have any coverage right now. So that's why we say there would be overall economies if you look at the cost of drugs as a whole, as a big bubble.
Okay, thank you. That's very helpful. Mr. Staples, if I can turn to you, and I wonder if you can comment. You've been very helpful in your passionate testimony, but either when you're talking about system-wide or individuals that you've been hearing from. But when when Mr. Frank talks about why don't we put the money into just targeting where the need is and kind of leave the rest alone? What are your thoughts on that?
Thank you. I mean, I hear you. We want to make effective use of public dollars. We want it to get to places where it is needed most. But the aims of the program, of the legislation, is not just to provide medication to Canadians, but is also to get the price of drugs lower. We've got to get the price down. So it's no surprise to hear criticism of bulk purchasing from, in the discussion today from certain quarters who don't want that. but I think Canadians do. Our healthcare system does. Right now, we spend as much on drugs in our healthcare system as we do on doctors. And in fact, only hospitals is the next higher up. So we've got to get the price overall of drugs down to a lower level. That's going to require a coordinated bulk buying strategy. You know, some provinces, not all provinces, pay the same amount for pharmaceuticals. There's different arrangements that are made, and as Mr. Giroux mentioned in his very interesting October 2023 report, said that increased transparency from a bulk buying strategy will help lower the costs to everybody, because all provinces will get the same price as opposed to one.
I'm going to cut in because I just want to hear from Mr. Blesky before my time is up. Mr. Blesky, you may have noted that the Yukon Territory was the first jurisdiction in 2020 to cover CGM. And I wonder what you think of, I mean, now other provinces have come on board with that, but when you look at the sort of the piecemeal approach versus a coordinated national approach, like how do you feel about how we can do better with a coordinated national approach, incorporating C-47 into this?
Yeah, I think that a coordinated national approach is really important because as we're starting to see, the international research consensus shows that CGM usage is tied very successfully to better health outcomes, and I think that the research in Canada shows the same thing. So when it comes to the federal government coming in and being a partner in supplying CGM technology to Canadians, I think it's a very strong step forward. Especially given, you know, not only is it effective for type 1 diabetes, but it's also very effective in monitoring blood glucose levels in type 2. And in fact, there are companies that are coming out with new CGM technologies that are specifically designed for type 2 diabetes, for prediabetes, and those with pregnancy that are monitoring their blood glucose levels.
Thank you. Thank you, Mr. Blesky. And next, Dr. Ellis, please, for 5 minutes.
Thanks very much, Chair. And again, thank you to the witnesses being here. Mr. Keon, I think we've heard some testimony that perhaps you could clarify or a question from Mr. Staples that medication costs might differ across the country. Could you tell us, is that true? And are there jurisdictions that have prices that are better than others in Canada?
Thank you for the question. Yeah, I should clarify. I'm here today representing the off-patent industry, the generic and biosimilar industry. We fill 75% of prescriptions for about 20% of the costs. So there's 80% of the costs that don't go through the companies that we represent here today. But as I've said twice already, we have a national system on pricing. Quebec participated in the latest round of negotiations for the first time. It is a national system. All provinces pay the same price. All payers in Canada pay the same price for generic medicines. And so when I say that we don't like bulk buying, I think we already have a national system that's negotiated with experts who run drug programs, leads to low prices. And that's what we want. We are concerned with terms like bulk buying if it implies that there's going to be some attempt to drive pricing down lower. Countries like New Zealand bulk buy. When we look at the data, they have fewer drugs available than elsewhere. And so that's not a system that we recommend. We have worked very hard with the PCPA, with the provinces, and the 3 federal drug plans to get a system, and we think that system should be respected.
Thank you very much for that. And through you, Chair, to the Parliamentary Budget Officer, you know, one of the things that does concern me is the loss of coverage on behalf of all Canadians, and you know, if you do some napkin-based math, you know, perhaps this program was based on 1 million people. If 40 million people are, you know, going to have to enter into this program, I mean, I can do the math in my head, but I'd like to perhaps hear you say it out loud with your credibility as the PBO. what would be the cost for simply these two classes of medications on the basis of 40 million Canadians?
That, unfortunately, I don't know off the top of my head. If all the
40 times the amount, would it not? I mean, is that not the math?
Lisa tells me that we have the numbers, so I'll probably let her speak. Sorry.
If you look at the table that we provide in our costing note, the very first line, the cost will amount to approximately 5.7 billion, would give you an estimation for these same drugs, if the program covered everyone in Canada, how much that would cost. And then you can see the cost recovery due to public plans or the private drug coverage,